Hello and welcome back to 90 Seconds Healthcare. My name is Dr. Samer Ellahham. I'm a cardiologist and a clinical professor. As you know, we have sections in the 90 Seconds Healthcare that are very brief. That's why we called it 90 Seconds Healthcare, going for only a few seconds. But, with the request that came from many of you, I thought that it would be interesting to have some of the slideshows to clarify some things. Our topic today is on cholesterol awareness. I called it breaking down the myth. Again, I hope you'll find this interesting. We'll move forward. So the whole discussion on cholesterol is one of the most debatable one, although really cholesterol or LDL specifically, and also triglyceride and non-HDL is no longer a theory now when we talk about heart disease or atherosclerosis, hardening of the blood vessel. Now it's a proven fact. So really for all of us, the first myth that we need to, get rid of or misconception is it's only a theory. It is not. From so many years and so many days, there are strong data looking at four different ways of looking at the data that show that LDL specifically is one of the single most important risk factors for hardening of the blood vessels. Hardening of the blood vessels. What am I talking about? So this is a blood vessel. This is the inner lining of the blood vessel. We call it the endo and inside thelium. Endothelium. And this inner lining has substances in it. I'm not going to bore you with the names that prevent the platelets, those sticky things that last for 7 to 10 days in our blood and they come back. We call them remnants of megakaryocytes, like they come from a large cell and they become platelets. And those are the ones, if I'm shaving or you are shaving or you're cutting yourself somehow and you see a small clot on your skin, most of this is platelet. These platelets are not supposed to stick to the inner lining of the blood vessels, otherwise we get a clot. And if we get a clot, we get a heart attack or a stroke or vascular death, we call it. If the cholesterol is elevated, again, especially if there is diabetes, especially if we have smoking in the patient or the person, if there is a strong family history of heart disease, if the person is somewhat older, although it doesn't have to be, you can see how these fatty molecules are engulfed by something called macrophages, some white cells, and they somehow disrupt the inner lining of the blood vessel. We call it the endothelium. And then it gets to be exposed to the blood, which is very, very dangerous because then the platelets, those small things with their red blood cells come in and they stick and they form a clot or a nidus, and that nidus brings more and more of the platelets, more and more of the thrombin, and a major clot would happen, such as here. The blood vessels came up, there is a clot, the red blood cells came up, and you could see how this would be seen in a left heart cath or a coronary angiogram. When we inject the dye in the coronary artery, we see that there is significant narrowing, is almost occluded, and that is very dangerous. It would cause chest pain, it would cause shortness of breath. The person may be sweaty, nauseated, vomiting, weak, etc. You could see that this is from the literature, not a patient that I know, someone who died and had an autopsy, what we do after the death. And you could see how, unfortunately, in this case, it was a right coronary artery, was completely occluded. And you could see that there's almost no space for the blood to go through. Magnify this, you would see that there were so many red blood cells and so many platelets with thrombin, and the clot formed very quickly. And that is what we need to prevent. And it is preventable. It is preventable. So we're always optimistic, smiling, and trying to address these things for health literacy. Lipid profile test, I'm sure you're aware, fasting or not fasting, just do it. As long as we know whether you were fasting or not, we can analyze this. It may make a 5% difference, especially when it comes to LDL. With triglyceride, it might make more of a difference, but just do it. If you could do it fasting 12 to 14 hours, it will be ideal. But if not, then go ahead and do it and let us know that you are not fasting. In one of my videos, I spoke about A, B, C, D, E, F, S. A is awareness, aspirin, etc. B is blood pressure. C is cigarette smoking. And I said cholesterol. D, diabetes, diet. E, exercise. S, stress management. But the C component is mostly related to the LDL, that nasty green gentleman who is not looking very friendly nor very kind, versus the poor HDL is the scavenger cleaning everything. So LDL should be low, HDL should be high. LH. LDL is bad. It takes from the liver, especially the cholesterol, and puts it in the arteries, as you've seen. You've seen that inner lining of the arteries, and you've seen how those arteries were clogged. So what do we do? So we looked at this where I am currently now. I'm in the United Arab Emirates, but also we looked at it in the United States and many other ways. And one of the ways that I think people are extremely confused about this is related to what is my LDL goal? What should my number be? It is not, arbitrary. It's not empirical. It's not based on the weather or the mood. It is based on the guidelines. And we have in the United States guidelines, we have in Europe guidelines, and in many other countries. We in this region have adopted, among others, the European Society of Cardiology guidelines. And I thought this figure is so easy to follow that maybe I can show it to you. And again, when you do the LDL, the low density lipoprotein, the bad guys, the bad, we can have millimole per liter as 1 unit, or we can have milligram per deciliter. So I put it, and the guidelines put it for us, so it's clear. So when if someone walks me, is walking the street or see me in the elevator, say, "Hey, you're a cardiologist. What should the LDL be?" I would obviously say there is no fixed LDL goal. The LDL is based on the risk that the patient carries, and I mean the cardiovascular disease risk. There is a calculator for this. We call it SCORE or Framingham, or the American College of Cardiology has its own calculator. But that's not really the point now. You can discuss it with your healthcare provider and have more details on this. What I wanted you to know is by no means is it acceptable to have our LDL more than 3 millimole per liter or 160 milligram per deciliter, no matter what our risk is. So at least we have the bare minimum is going to be 3 millimole per liters or 160 milligram per deciliter. But what happens if the person is at a higher risk, such as a diabetic person, or if this patient is diabetic with duration of less than 10 years, then we are going to have to ask the LDL to be lower and make it lower. 2.6 millimole per liter, 100 milligram per deciliter. What if the score risk of the patient is higher, or the patient has a very strong family history, or they have moderate kidney disease, or the patient has diabetes for more or equal to 10 years and they have end organ damage? Then we have to go lower, 1.8 millimole per liter or 70 milligram per deciliter. What if somebody had a heart attack, or they had a CT coronary angiography and they found to have major calcification, or they were found to have significant or some stenosis in their arteries? What if they had even end-stage kidney disease or severe kidney disease? Then we have to go lower to 1.4 millimole per liter or 55 milligram per deciliter. What if the person, I will show you in the next slide, had two events, two heart attacks or heart attack and a stroke? Then we need to go to 40 milligram per deciliter or 1 millimole per liter. What's the message? Message is, number one, not much confusion about LDL or cholesterol. It's not a theory. It's a fact. It's a major risk factor for vascular disease, heart, neck, lower extremities, etc. Message number two, we don't make decisions, based on the mood or the weather or how the day is. We make decisions based on the guidelines, and we individualize the case or the care based on the individual risk of the person. We call it the cardiovascular risk, as I try to summarize in the slides. Number three, the bare minimum that we accept when we lower the cholesterol, the LDL, is 3 millimole per liter or 160 milligram per deciliter. The higher the risk, the lower. So it's very, very clear. You can even look at it yourself and review this video. Number four, we will go to our healthcare provider and discuss what's best for us. And number five, lifestyle changes, medications, or anything else that needs to be done should be individualized and discussed with your healthcare provider. I thank you for your attention. I hope I've made some things clear. You can reach out to me on 90secondshealthcare@gmail.com or samerellaham@gmail.com. Please stay safe. Please increase your health literacy and please rely on the right information. I highly recommend the international, local, European, American, whichever guidelines you believe in, to stick to an evidence-based decision making, even on social media. Thank you.